Let's start with a quote that every single anesthesia provider needs to have burned into their memory. This one sentence really sets the stage for everything we're about to talk about. It highlights just how high the stakes are.
All right, welcome. This is our high-yield review of neonatal anesthesia. So whether you're getting ready for boards or just want to sharpen your skills in the OR, we're going to break down the absolute must-know concepts for your tiniest, most fragile patients.
Here's how we're going to tackle this. We'll follow a pretty clear, systems-based path. We're starting with the fundamentals, then diving deep into the airway, moving system by system, and then we'll wrap it all up with a rapid-fire review to make sure these key concepts really stick. So, before we jump into all the complex physiology, let's start with the absolute basics: how we communicate and how we monitor. Getting these right is the bedrock of keeping these little ones safe.
You know, interacting with parents is a skill in and of itself. Remember, you're not just taking care of a baby, you're taking care of a whole family. Use simple language they can understand, project a sense of calm even if you're not feeling it inside, and make that consent process a real conversation, not just a lecture. Kids are so perceptive. Your calm vibe directly helps make their anesthetics safer and smoother. Okay, let's talk about monitoring. We have all our standard ASA monitors, but for a neonate, you could argue the pulse oximeter is their most important lifeline. And here's the critical take-home point. You never, ever silence your alarms for a long time. It's dangerous and it's a huge violation of practice standards. At the end of the day, all this technology is just an aid. Your best monitors will always be your own 2 eyes and ears.
And now, for what is, without a doubt, your #1 priority, the neonatal airway. This is probably the highest risk part of pediatric anesthesia, and you absolutely have to master its unique challenges. It's just non-negotiable.
So, take a look at this. This chart breaks down the challenge perfectly. Look at these differences. You've got a huge tongue and a tiny mouth, a larynx that's way up high and forward, and this long, stiff, omega-shaped epiglottis. Every single one of these things makes just getting a view with a laryngoscope tougher and makes airway obstruction more likely. And that trachea, it's so compliant it's almost floppy, which means you can lose the airway really quickly and quietly. And this slide right here explains why all those anatomical differences are so terrifyingly important. Neonates have a teeny-tiny functional residual capacity. That's their oxygen reserve tank, but their metabolic rate is burning through oxygen 2 to 3 times faster than in adults. So what happens? If their airway gets compromised, they don't just slowly drift down, they plummet. There is literally zero room for error.
Okay, building on that, let's talk about gestational age. Knowing your patient's background, how old they are, how they've been growing, isn't just trivia. It directly tells you what physiological risks you need to be watching out for.
We basically group neonates into 3 buckets: preterm, term, or postterm. Now, each group has its own special list of worries, right? Like respiratory distress in preemies or meconium aspiration in postterm babies. But do you see the one risk that shows up in every single category? Hypoglycemia. It's the universal threat. It should be on your radar for every single neonate, no matter what their gestational age is.
Now, when you're trying to figure out if a baby is doing okay, weight is your best friend. Here's a super simple high-yield rule to just lock away for your boards. A healthy baby should double their birth weight by 6 months and triple it by 1 year. It's a fantastic, quick and dirty way to know if they're thriving.
Okay, let's shift gears and talk about one of the most incredible, dramatic events in all of human physiology, that switch from fetal to neonatal circulation. Understanding this cascade is absolutely key to managing these tiny patients right after birth.
Think of this whole thing like a chain reaction, or a set of dominoes. First, you clamp the cord. That gets rid of the low-resistance placenta, and bam! Systemic vascular resistance skyrockets. At the exact same time the baby takes its first breath, the lungs inflate, and pulmonary vascular resistance plummets. That massive pressure shift slams the foramen ovale shut. And finally, that rush of oxygen in the blood tells the ductus arteriosus, hey, time to close up shop. It's just a beautiful, perfectly timed sequence.
So why does this all matter? Well, because a neonate's cardiac output on a per kilo basis is a staggering 2 to 3 times higher than in adults. And that number explains almost everything about them. It reflects that incredibly high metabolic rate, their high oxygen demand. It's why they breathe so fast and why they desaturate in a heartbeat.
All right, now as we look at the rest of the organ systems, there is one single theme that connects everything, a unifying concept that explains almost every major anesthetic risk: functional immaturity. Their organs are all there anatomically, but they don't work very well yet.
This slide really connects all the dots for you. Their kidneys are immature, so they can't hold on to sodium and bicarb very well. That makes them prone to acidosis. Their liver is immature, so it has terrible glycogen stores, which leads to, you guessed it, hypoglycemia. A weak esophageal sphincter means a huge risk for reflux and aspiration. And an immature pancreas in a baby whose mom was diabetic can cause a massive rebound hypoglycemia. See the pattern? Each system's immaturity creates a specific, totally testable problem for us.
Let's do a real quick hit on hematology. So newborns have a really high hemoglobin, but it bottoms out. That's the physiologic nadir, around 3 to 4 months. They're also swapping out their fetal hemoglobin for adult hemoglobin, which is way better at dropping off oxygen to the tissues. But here's the most critical part. Their vitamin K-dependent clotting factors are really low, which is exactly why pretty much every newborn gets a shot of vitamin K to prevent bleeding.
All right, we have covered a ton of ground. So now, let's lock it all in with a rapid-fire review. These are exactly the kinds of questions you should expect to see on your exams. You ready? Let's do it.
First question. A normal neonate's EKG will show T-wave inversions over on the right side of the chest. That's part of the heart switching from right to left-sided dominance. So, what would you see that would make you worry about a problem like right ventricular hypertrophy?
And the answer is the failure of those T-waves to invert. If those T-waves stay upright, that's a huge red flag that the right ventricle is still under too much strain.
Okay, next one. This is a classic clinical setup you'll see all the time. Mom had gestational diabetes. What is that baby's #1 metabolic risk the second they're born?
The answer, of course, is rapid and severe hypoglycemia. Think about it. The fetus was swimming in high glucose from mom, so its own pancreas started pumping out tons of insulin to compensate. But once you cut the cord, that fire hose of glucose is gone. But the baby's insulin levels are still sky high, and that causes their blood sugar to just crash.
All right, last question for this round. A key developmental milestone we talked about. By what age should a healthy baby's birth weight have tripled?
And the answer is 1 year. Double by 6 months, triple by 1 year. Just remember that simple rule. It's a fantastic marker of a child's overall health and well-being, and it's the perfect high-yield fact to end on. Great work.
All right, welcome. If you're getting ready for your boards, or you just need a really solid refresher on neonatal resuscitation, you have come to the right spot. In this explainer, we're going to break down all the critical, high-yield stuff you absolutely have to know for your exams and for when you're out there in the real world. Okay, so here's our game plan. We're going to kick things off with your role. What are your goals? Then we'll dive into the incredible physiological changes a newborn goes through. From there, we'll hit the assessment tools, walk through the resuscitation algorithm step by step, touch on some really high-risk conditions, and then wrap up with some calculations that you are definitely going to want to have locked down for your exam.
All right, first things first. Let's talk about the medical legal side of things. This is huge. Before you even think about touching the baby, you have to remember one thing. Your primary, #1 responsibility is always the mother.
So you can only go help that neonate once you are absolutely sure the mother is stable. That's a huge judgment call, and it's all on you. And get this, legally, you actually need her consent to leave her side. Now, once you do step in to help the baby, your goals are pretty straightforward, but so important. Keep them warm to stop heat loss and be ready to jump in with PPV or CPR based on those really clear heart rate numbers.
Okay, now let's get into the why. Why is resuscitation even necessary sometimes? Well, it's because neonates face these enormous physiological challenges the second they're born. It's a huge transition. We're going to focus on the most critical pieces you really need to grasp.
Okay, this is a big one for exams. Do not get PPHN and TTN mixed up. Here's the easy way to think about it. PPHN is a plumbing problem, a vascular shunting problem. Stressors like hypoxia make the blood just bypass the lungs. TTN, on the other hand, is a fluid problem. Think wet lung. It's all about feeling to clear that fetal lung fluid, which is why you see it so often in C-section babies who didn't get that big squeeze from labor.
So this number, 2 to 3 times, really tells the whole story of why keeping a newborn warm is literally life-saving. Their little metabolic engines are revving 2 to 3 times higher than an adult's. They make heat by burning this special brown fat, that's non-shivering thermogenesis. But here's the kicker. That process burns through a ton of oxygen. So cold stress isn't just about feeling chilly. It's an oxygen-sucking crisis that can quickly spiral into metabolic acidosis.
Okay, so the baby's born. How do we figure out what's going on? And fast. Let's walk through the key tools we have, and we'll start with the more subjective stuff and then get to the hard data.
The APGAR score. You know the drill. We do it at 1 and 5 minutes. Now here's a pro tip for your boards. They're probably not going to make you calculate one from scratch, but you have to know what it means. And a low 5-minute score, that's a huge red flag. It's your signal to say, okay, I need more objective data, and that means getting cord gases.
Speaking of cord gases, this is where we get the real story. It's way more objective than an APGAR. And if there's one thing you take away from this slide, it's this. The type of acidemia is everything. Think of it like this. Respiratory acidemia is a ventilation problem. We can usually fix that pretty quickly. But metabolic acidemia? That tells you there's been a deeper, longer-lasting insult at the cellular level. That's the one that really gets your attention.
All right, let's get to the main event, the neonatal resuscitation algorithm. This is the playbook. We're going to walk through the key decision points that you have to know like the back of your hand. No hesitation.
Okay, the clock is ticking. In those first 30 to 60 seconds, you have a simple checklist. 1. Warm and dry. 2. Position the airway. Get them in that sniffing position. 3. Stimulate them. And 4. Assess. And here's a really important update. We are not routinely suctioning anymore. Why? Because it can cause a nasty vagal response in bradycardia. Only grab that suction if you see something clearly blocking the airway.
Okay, here it is, your first big fork in the road. Is the heart rate below 100, or are they not breathing? If the answer is yes, you go. Now, there is no let's wait and see. You act.
And what's that action? It's starting positive pressure ventilation. This is the single most important thing you can do. You're literally trying to pop open those sticky, fluid-filled alveoli for the very first time. That's why giving that first breath, a little prolonged inspiration, can make all the difference. All right, next critical checkpoint. You've been bagging for 30 seconds, you know you're getting good chest rise, but that heart rate just isn't coming up. If it's still stuck below 60, it's time to escalate, immediately. So, heart rate is under 60 despite good PPV, what do? Two things happen at once. Start chest compressions and get ready to intubate. Secure that airway. After those are going, now we can think about meds like epinephrine or maybe a fluid bolus if you suspect hypovolemia. And notice what's not on this list. We're not reaching for atropine or bicarb here. That's an old way of thinking.
Quick clinical pearl, and this is a classic board question. What's the ratio? It's 3 to 1. 3 compressions, 1 breath. 3 to 1. Just burn that into your brain.
Okay, let's switch gears and talk about a few high-risk congenital problems. But before we do, you have to remember one core physiological fact about newborns. They are obligate nose breathers. They have to breathe through their nose. So what does that mean? It means any little blockage in the nose or upper airway isn't just an inconvenience, it's a full-blown, life-threatening emergency.
So, this is your red flag cheat sheet. If you see a baby who pinks up when they cry but gets dusky when they're quiet, that's choanal atresia. You gotta think nasal blockage. You see a sunken-in, scaphoid abdomen. That's a congenital diaphragmatic hernia. Their guts are up in their chest. And if you see the turtle sign during delivery, that's shoulder dystocia. Every single one of these demands a very specific, immediate response.
All right, let's wrap this up with some high-yield math and concepts that you're almost guaranteed to see on an exam. These really show you understand the underlying physiology.
Okay, calculating allowable blood loss. I can almost promise you'll have to do this on a test, so let's nail it down. It's just 2 steps. Step 1 is finding the estimated blood volume, or EBV. For a term baby, the magic number is 85 mils per kilo. So if we have a 4-kilo baby, you just do 4 times 85, that's 340 mils. Easy enough. Now for step 2, you plug that into the ABL formula. It's your EBV times your starting hematocrit minus your target hematocrit, all of that divided by the starting hematocrit. So for example, it's 340 times, let's say 36 minus 25 divided by 36. You run the numbers and you get about 102 mils. That's how much blood they can lose.
All right, here's a classic physiology brain teaser, and it's all about Poissier's law. You know the one, resistance is inversely proportional to the radius to the 4th power. So let's imagine an allergic reaction cuts an infant's airway radius in half, say from 2 millimeters down to 1. What happens to the airway resistance?
It goes up 16 times. I mean, think about that. It's not double, it's not triple,
It's a 16-fold increase. It's absolutely catastrophic. And this one concept, right here, is why a tiny bit of airway swelling, just 1 millimeter of edema, can make a neonate crash. The work of breathing just skyrockets.
So, let's tie this all together with the big takeaways for your exams. Remember, neonates aren't just tiny adults. They have different drug dosing, a totally unique airway, they're incredibly vulnerable to getting cold, they burn through oxygen like crazy, and most big birth defects are going to show up first as trouble breathing.
And that brings us to our final thought. Thinking about that 16 times increase in resistance, what's the single most important airway device you need to have ready? Well, the real answer isn't a device. It's anticipation. It's being prepared. It's having all your difficult airway gear, your smaller tubes, your LMA, right there at your fingertips before things go south. Because in the end, your preparedness is what will guarantee a safe outcome. Thanks so much for joining me.